Welcome back to Cutting the Boards. In today's video, we will discuss 25 breast topics that will certainly be on the exam. So number one, fibroadenoma or phyllodes tumor. So if the patient is less than 35 years of age, you can proceed with an ultrasound. If the patient's greater than 35, you would go with a mammogram. A core needle biopsy is needed if there's any uncertainty. And then if the core needle biopsy is benign, you can proceed with 6-month ultrasound follow-up. For number two, most common cause of bloody nipple discharge is going to be intraductal papilloma. For number three, greater than 60 years old with unilateral nipple discharge on Absite, this is always malignancy until proven otherwise. For number four, breast abscess, especially during breastfeeding, is the most common time to get this. So if concerned, if there's an abscess, you would aspirate, and then you can tell the mother to continue breastfeeding along with antibiotics. The key here is to avoid an incision and drainage, as this could cause a potential milk fistula. For number five, a buzzword on Absite is typically radial scar, and this can stand for sclerosing papillary or ductal proliferation. The answer always is going to be an excisional biopsy in that case. Getting into more lesions, so number six, atypical lobular hyperplasia. So this is not pre-malignant, so it's different than the other lesions that you can find. It's a marker of 8 to 12-fold greater lifetime risk, and that can be in either breast. And then the diagnosis is a core needle biopsy, and then the treatment is excisional biopsy to evaluate for pathology. For atypical ductal hyperplasia, so that's a 4 to 5 increased risk of invasive cancer, the diagnosis is going to be a core needle biopsy, and the treatment is going to be an excisional biopsy, and that's a 9 to 30% incidence of DCIS on excisional biopsy. Number 8, for LCIS, this is a 40% risk of cancer in either breast, and the treatment is to excise with wire localization. And the high yield portion here is if there's a positive margin that there's no need for excision, so that's a very highly testable topic. And then the caveat for this, which I've seen in the past, is when they discuss pleomorphic LCIS, you actually treat this like a DCIS and then you re-excise the margins. For number 9, for DCIS, so this is a 50% risk of malignancy in the ipsilateral breast, and then 5% in the contralateral. The diagnosis is going to be a core needle biopsy. On mammogram, you'll often see calcifications in the area. So the key points here are that breast conserving therapy with lumpectomy and adjuvant radiation. And then the caveat of this is if comedonecrosis, then simple mastectomy with adjuvant chemotherapy. And then in patients, especially that are pregnant, who have contraindication to radiation therapy, the treatment of choice is going to be a simple mastectomy and then a sentinel lymph node biopsy. And then the reason that you do a lymph node biopsy is because you're changing the breast drainage with a mastectomy, and there is a high risk of upstaging cancer from DCIS to an invasive malignancy after completing the procedure. And then the margins, this is also tested as 2 millimeters for DCIS, which you'll see will be different from invasive carcinoma. So number 10, adjuvant therapy in premenopausal women will be tamoxifen, and postmenopausal women will be an aromatase inhibitor. Number 11, so screening is highly testable, so start at age 40, every 2 years, and then annually after age 50. And then in patients with genetic mutations making them high risk, you start 10 years before the youngest age of diagnosis in a first-degree relative. Number 12, it's important to know the BI-RADS classification. I'll get to this on the next slide. And then 13, the TN and metastases, staging, and treatment are also very important to know because it's different treatments for how you stage your patients. And number 14, inflammatory breast cancer. So high yield on the Absite, any dermal description, any erythema or redness, I would have a high suspicion for inflammatory breast cancer. And this is by virtue of lymphodermal invasion. It's going to be upstaged to at least a T4. So treatment for this is neoadjuvant chemotherapy, modified radical mastectomy, and then adjuvant chemoradiation therapy. And then number 15, I've seen it come up in the past with male breast cancer. The treatment of choice is going to be a modified radical mastectomy in these patients. So this is the BI-RADS classification. Important to see here that in category 0, it's basically incomplete, meaning that we need additional imaging, and then proceed with additional imaging. For category 1, it's negative, routine mammogram or screening, same for category 2. Category 3 is probably benign, so short interval follow-up is needed. For Category 4, that's when you start to get into suspicious, so this is a tissue diagnosis is needed. Category 5, a tissue diagnosis is also needed, and there's a very high likelihood of malignancy. And then Category 6, you'll see on imaging, like say you get a staging MRI after confirmed diagnosis of breast cancer, then that would be technically Category 6. Also important to know the T, N, and M staging for your patients, and you can just study this slide listed here. So moving along, breast-conserving therapy for lobular carcinoma or ductal carcinoma will be a lumpectomy, and then whole breast radiation, and then sentinel lymph node biopsy to adequately stage the axilla. So the margins here will be no incon tumor, so that's different than DCIS. And then if during pregnancy, then cannot have breast radiation, then you'll proceed with, mastectomy because breast-conserving therapy is contraindicated. In number 17, the Z11 trial is a trial that often comes up clinically. So this is in patients with T1 or T2 breast cancer and less than 3 sentinel lymph nodes positive. Breast-conserving therapy and whole breast radiation therapy is preferred as there's no benefit to axillary dissection in these patients. Number 18, for a patient with chronic lymphedema for 10 years following axillary dissection, especially if they describe discolored lesions, would have a high suspicion for lymphangiosarcoma. Number 19, if concerning lesions on mammogram and then the core needle biopsy returns normal, proceed with an excisional biopsy for discordant findings. And then number 20, really important to know who's going to get neoadjuvant and adjuvant chemotherapy. Anatomy is pretty high yield, so for axillary lymph nodes, no level 1, no level 2 and 3. Important to know that level 1 and 2 are resected for breast cancer, whereas levels 1 through 3 are resected for melanoma. And then a few of the nerve deficits for wing scapula, it's an injury to the long thoracic nerve. If there's a weakness in arm adduction, it's injury to the thoracodorsal nerve. For 24, if there's sensory deficits to the medial arm, it's an injury to the intercostrobrachial nerve. And then the medial pectoral nerve innervates the pec major and minor, whereas the lateral pectoral nerve only innervates the pec major. And then as a bonus point, I've listed the boundaries of the axilla. Really important to know these, as they could just ask, a simple anatomy question asking which wall is constituted by which muscle or what structure. So important to know. So that was a quick review of 25 breast topics that will likely be on the exam. Again, good luck studying. Thank you for tuning in to Cutting the Boards, and I'll see you in the next video.